Hi, and welcome to the Healthcare CEO Show, where you'll find actionable insights on healthcare leadership from the best and brightest in the industry. I'm your host, Daniel Fernandez. Let's get a pulse.
With me today, I have Bill Hercules. Bill is the founder of WJH Health. He's planned or executed $9.7 billion worth of work for some of the largest organizations in the country, some of which include Baycare, AdventHealth, Johns Hopkins, and Nemours, to name a few. He's also an accomplished architect, community leader, contributing author, and public speaker.
Thank you, Daniel. I'm pleased to be here. You know, we're in a very strange point in time right now where everybody is very confused. They're wondering, how do we get back to normal? Because there's safety and security in normal. But there have been a number of things that have been disrupted that actually have a very interesting historical perspective. About 25 years ago, the American Institute of Architects, Academy of Architecture for Health, did a very provocative at the time national conference. It was held in Pittsburgh, and it was titled The Bedless Hospital. Imagine a hospital without any beds. And again, this was the late 1990s, mid to late 1990s. And the historical context of that was a collection of things that were happening within the federal space around reimbursement. Capitation was a word that was starting to float around, and nobody really understood how to deal with that. There were some systems, integrated systems on the West Coast, Kaiser and others, that were essentially doing that as a completely integrated system. But the feds were really trying to dig deep into this. So you may remember Hillary Care as a component of that. The federal government also had a problem balancing its budget, and there were a number of things that were sort of tied up in both of those initiatives that made federal reimbursement a little tighter. At the time, we were pursuing what we thought were pretty good sized $20 million projects, significant expansions, that sort of thing. But those were sort of compressed while the feds were really working on all of this. So fast forward just a little bit, Hillary Care didn't proceed. The feds ultimately did get their balance back to the budget through the Balanced Budget Act. And the pent-up demand associated with those $20 million mushroomed them into $100 million projects. So this was in the early 2000s. Suddenly there was a building boom in hospitals. What we didn't have then was some things that we actually do have right now, fast forwarding 20 years. And that's the IT infrastructure, the health informatics, the predictive analytics, artificial intelligence, et cetera, that simply didn't exist 20 years ago. But we do have that right now. In fact, I heard a COO recently say, it used to take us 2 years to get an app built. Now we can do it in 3 weeks. Well, but when pressed into it by the emergency of what COVID is, a number of things can really happen, but the technology does exist. And it affords us a very interesting lens into what the future might be, sort of a hybrid of physical places and virtual places in very real ways across the entire continuum of clinical and ambulatory care up to and including critical care. So there are a number of models that are being explored, but it hasn't been built yet. So the experimenters are still down in their basements tinkering around with things.
Are there any examples you can think of maybe facilities or organizations that are doing it well today?
Well, as I had mentioned before, the Kaiser organization really built themselves around a completely integrated model. Back in the 1940s, they offered an insurance product which was more than just insurance. It was a completely integrated approach to taking care of one's health. And they really figured out early on that part of the equation was controlling the costs of hospitalization, of physician visits, which even now are two separate entities. They're two separate lobbying groups. They're billed differently. It's still a bifurcated system. But as Kaiser had developed their system, it was a fully integrated system. It's not necessarily a panacea, but it is an integrated system. So if we look back maybe 10 years ago, when the Affordable Care Act was being developed and ultimately ratified by the Obama administration, there were a number of attempts to create a governmental system that was essentially fully integrated. And there were a number of other elements around that, ACOs and others, that attempted various components of this. So what does it mean in terms of the physical places? There are a number of nuances around this, but I think the biggest way forward here is in the difference between the demand for a physical place, which is expensive and inflexible largely, and a very flexible virtual space. And I would argue that you need both of them even right now. While all of us have iWatches that can do EKGs, and even the newer ones can do a pulse ox, it doesn't necessarily replace what a physician in a very tactile way can experience and enhance their diagnostic qualities.
Yeah. I mean, do you believe that the way facilities are designed in the future will change? I mean, for instance, I remember dedicated admin buildings, in the past.
Well, I had a very interesting discussion with a number of HR people on an ACHE webinar a few weeks ago. And I asked the question, because I was the only architect in the room. I said, well, given all the things that you're talking about the stress associated with COVID and how you're dealing with that, some systems are trying to not lay people off and repurpose them, et cetera. So it was sort of about the tactics of how do you keep the team together and keep everybody happy and focused while the house is still on fire. But I asked the question, looking forward, what does this mean? And to a person, they all said, we are looking at divesting ourselves of kind of the softer administrative space. My words, not theirs. But any place that we don't need to have our people stationed, or we can otherwise deploy them in another venue like home, we're going to seriously explore that. The benefits associated with working from home for the staff, at least in the short window that we've seen, apparently are, from a lifestyle perspective, significant. From a teaming perspective, the jury's still kind of out. They still want to try to get everybody together as a team and remain focused. Otherwise, it winds up being a transactional work piece kind of gig economy, which they don't really want to create culturally. So it's going to be interesting to see how all these things happen. But the softer space, administrative space, some physician offices, I think the demand is going to significantly shrink for those kinds of spaces. Florida, Arizona, Texas, California, some of the Sunbelt states that have a larger in-migration of retirees, baby boomers, perhaps not, they're not going to see that as readily, but other places where the baby boomers are coming from, we'll see that fairly drastically, I think.
Now, conversely, on the flip side of that, when it comes to specialized procedures and rooms, I've been to many facilities where everything's been crammed. Now, maybe there would be a renewed focus on more of the human experience, and maybe there are some abilities there to enhance in some way.
Well, a number of systems have been talking about their patient experience for really decades. Wow. When the Picker Institute and Press Ganey, a couple of organizations that actually measure patient engagement, would you refer your friends to this hospital or this health system? So they've been focusing on this for a while. CMS has a component of their reimbursement structure tied to the patient experience. So they got their attention financially as well. But to try to understand what that means is a lot more art than science. The broader issue, in my opinion, is not just what does the space feel like, and does it feel like a spa? And we've heard all the kinds of ridiculous buzzwords about it should be hotel-like, it should be spa-like, it should feel like home. It should. Well, the reality is you don't go to a hospital because you want it to feel like home. You go to a hospital because you've got an ailment and you're hoping that they're going to take care of you, and you want to get out. You don't go there for vacation. You go there for a specific reason. So paying attention to those experiential pieces is extremely important. There are some systems that have engaged the Disney organization, for example, to help with that. But it becomes a much broader branding issue. What is it that we want to say to the community about our system in the way that, to frame an expectation of an outcome, to frame an expectation around care, the follow-up beyond coming into the bricks and mortar space. And that plays itself out, obviously, in the physical space, but also in a virtual space, which is, quite frankly, a lot easier and adaptable and more rapidly so.
Yeah, I mean, it's there are things that I've learned about in the last year that I'd never even would have even thought of. Like, for instance, virtual waiting rooms. It's something I wouldn't even have thought of 6 months ago, but now virtual waiting rooms just comes up in conversation now.
Right.
Especially things like Zoom. We're having this call on Zoom. A year ago, I wouldn't have known much about Zoom, but we're using Zoom today. So it's in a lot of companies that even we're talking to, there was this roadmap that they had over the next 2 to 5 years that seems to have been compressed. I'm also seeing a lot of innovations in the space, which is also exciting as well. We talked about mobile tech and apps and really the role in medicine. And data and science and AI. I have a passion for architecture, but never really took it beyond Legos. It's just
Right.
The world we're in now is so fascinating to me, and it can also be exciting. So I think that there's also some opportunity there as well.
I think that there's going to be a very interesting transformation in the space of designing buildings, or even why should we have a building? Fundamental questions like that, which as an architect, and certainly if I was with a large firm, where our incentive is around, we've got to have a lot of projects to keep our machine moving. And that's not a casting aspersions on the business model, but it sort of is what it is. But also a hospital-based or hospital-centric business model is about a similar kind of thing. We need to have heads in beds in order to make our margin. So I think that there's some fundamental questions that CEOs that I'm talking to are asking about. Should we even have these same kinds of buildings that we've historically had? And that digs into a more fundamental question about what the benefit of those assets are, typically by virtue of their expense, by virtue of their ability to cocoon its occupants in a safe way. The systems are extremely complex, and then because of that, extremely expensive. It winds up being a very inflexible asset when you create something that's built like a Swiss watch, and then you've got to unwind it in a few years. Well, that simply doesn't happen. So operationally, what happens is a number of workarounds, and it begins to sub-optimize the operation over time. So it really begs a bigger question: should we be looking at hospitals that are 50-year buildings, and we continue to operate like that, or is the lifespan of a building going to be shorter? Is its ability to adapt, just like we've had to deal with the adaptation of COVID types of spaces? Those are all makeshift kinds of solutions, but there are ways of developing and anticipating various approaches to what might happen in these spaces into the future, and creating the added adaptability around how this might develop into the future. So software is a lot easier to customize than physical architecture is. Concrete is still not flexible, but the ability to adjust the operations with a variety of multi-purpose kinds of spaces is sort of what I think the future is going to be.
Nice. You touched briefly on margin, and margins haven't notoriously been very large to begin with, and probably less even more today. What is the sort of the correlation between margin and mission? I mean, you obviously need to continue to pursue your mission, but also be financially responsible as well. So how do you think it'll drive some decisions?
If we look at how the healthcare systems across the country are structured, some of them are government systems, some of them are for-profit systems, some of them are not-for-profit systems, but they all rely on the ability to create some sort of operating margin to sustain themselves. And especially in the not-for-profit space, those margins have been historically thin. You know, a famous quote from maybe 25 years ago, the Wall Street Journal did a not terribly ingratiating article interviewing the then chairwoman of the Daughters of Charity Health System. And they called them the Daughters of Currency because at the time they had a multi-billion-dollar war chest of investments. And her comeback was, we make so little money on our hospital operations. We're providing free care. We're doing so because that's our mission. Look at me. That is our mission. Make no bones about it. But we've got to be able to sustain that through some other financial mechanism, like our investments, in order to keep that mission going. So out of that, I think came the term no margin, no mission. So if we look at historically what those margins have been, they're in the 2%, 3% range, maybe a little bit better if the economy is really going well and their investment portfolio is doing well. But I saw some numbers recently published by an organization in Chicago called Kaufman Hall that have basically prognosticated through the end of the year, most hospital systems across the country will lose about 1%, best case. Worst case, more than 10%. And if you're operating on a very, very thin margin, you're taking a pretty significant hit. So what this means in terms of hospitals' ability to pivot and deploy future capital for any kind of innovation. IT infrastructure, facility capital investments, investing in innovation, investing in additional people is going to be significantly hampered. Some of them have accumulated enough of an investment portfolio that given how the stock market has performed, has buoyed their ability to remain solvent, but they're stressed right now. And the federal government is still all over the map about how they're going to reimburse for things like virtual care. It looks like it worked. Well, maybe it costs less. Well, maybe we shouldn't pay as much. You know, and meanwhile, the hospitals are extremely stressed financially, trying to do the best they can in really kind of warlike conditions.
Yeah. For the person listening today, who's our CEO, president, and so on, what would you like them to know about the architectural space? And maybe if they wanted to reach out to you, what are some sort of common things that may come up in conversations you'd want them to know about?
Well, I think that the need for physical space is going to remain. Okay. And I'm trying to develop a rubric around this, and I'll probably be publishing it in the coming months just to kind of clarify it. But it basically is built around the idea of if you need dedicated teams that are highly skilled and trained that you can't otherwise assemble in a virtual way, and they need to be there physically to deal with a physical patient who has a very complex collection of maladies, comorbidities, etc., then you're going to need a place for that team to gather around that patient. And if you have a need for some sort of invasive intervention, like a cath procedure or a surgical procedure, where the environment of care has to be extremely closely monitored, you're going to need a place for that. When there's a catastrophe that happens and nobody really knows what's going on yet, you need a place for that, those activities that have highly specialized pieces of equipment and responsive teams to be centered, and the emergent cases come there. So those three cases, I think, are going to require some sort of physical space, because it's about the risk calculus of not having closely controlled environments, or you can't widely distribute extremely expensive, highly specialized equipment, or people for that matter, ubiquitously. So I think that there's a need for, and a future need for, physical space. Everything downstream of that, there are some systems that are talking about hospital at home, where inpatients are being discharged from surgery or from an ED where they would normally go upstairs into an inpatient room. They're being discharged at home, and they're given some technology to use to monitor vital signs, to check in with nurses and physicians, et cetera. So, and the cost associated with that is significantly less on an episodic basis than an inpatient stay in an acute care environment. So it really begs the question, well, should we build any more acute care beds, or should we be looking at only critical care hospitals and maybe some sort of step-down unit, which is basically preparing you to go home? Are the physicians comfortable with that? Is the risk associated with that acceptable? What are the bioethicists saying? Their institutional review boards. So there are a number of elements around what this is that still haven't been perfected yet. And there will be a number of cases that try this. But I suspect that we're going to be moving into a very computer-centric kind of space, and that's going to be the underlying platform of the system of the future. In fact, a few years ago, I did a talk called The Hospital of the Future, and I put up a picture of a data center, all these server racks. And essentially, I think that that's what the future is really going to be built around. But there will be reasons for places for care, really to manage the risks associated with environmental issues, or reasons for collecting very expensive and highly trained people.
Wow. You've certainly given us a lot to think about. And I would love to check in with you down the road to see how this all plays out, because I think a lot of people are obviously interested in what happens in this space right now.
Well, I am too. I mean, I'm sort of spitballing here, and nobody's got a good crystal ball. So, but just looking at the convergence of a lot of these different effects right now, I think that there's some very interesting opportunity. And it begs the bigger question, do these systems have the courage to step out of the channel that they've been swimming in for the last, 50 or 60 years, some of them 100 years, into doing something completely different? Does this offer an opportunity for other startups to just offer a collection of services and do things very differently? What's the regulatory environment going to be associated with this? Who really knows? What's the payment environment? I mean, we do have socialized medicine. We've had it since the Medicare Act of 1965. So it's just a matter of degrees, really. So what's the payment structure associated with the government paying or insurers paying? And all of that has a variety of, it's really a very complex problem. So, complex theory comes into play here in a very real kind of way, but it's exciting.
It is. It's in talking with some other CEOs, I've asked a few of them, I'm like, what is the one thing I could give you that would help you to navigate this space? And a few of them have said, crystal ball. I think we all want that crystal ball.
Well, I think that there's especially for the not-for-profits, but even for the for-profits, sometimes they get a bad rap because they're for-profit. Well, they're providing a service. Their business model is different, but if you show up in an ED at a for-profit hospital, they're going to take care of you. If you've got a problem to deal with, if you need your gallbladder taken out or your knee repaired, they're going to take care of you. Right. So I guess the bigger issue is how does their business model relate to their fundamental promise that they're making to their communities? Right. The for-profits and the not-for-profits, and even the government hospitals, have a clear mission to typically improve the health of the patients that they serve, or some variation of them. There are a variety of other missions around, but something that I work with my CEO clients to address is how are we taking the decisions and the ideas that we're talking about and connecting those to the fundamental promise that you've made to your communities. And if we can't look at people at the grocery store as the CEO of the hospital and say, look, this promise that I'm making to you is very personal because it's personal to me, and this is how we're trying to deal with it. If we can't deal with it at that fundamental level, then something's very broken. And the people that I'm working with are completely bought into this idea. They wouldn't be in the space if they weren't. I mean, they really do care about what they're doing here.
Wow, that is a powerful message. Thank you for joining us on the Healthcare CEO Show. If you've enjoyed this episode, don't forget to subscribe on your favorite podcast platform for more insights from the top. Until next time, lead boldly and care deeply. See you on the next episode.